Well, thank you everyone for your patience and for joining us today for this very important special session. I'd like to thank the AACR, San Antonio Breast Cancer Symposium, and Tiger Lily for sponsoring this session on, I call, instilling trust in science and medicine. Obviously, this is a critically important topic, particularly in the age of the pandemic that we're in. Oh, Lori, come on and please join us up here. And today we're going to have kind of an unusual format, right? We'll have two presentations, one from Dr. Wilson, one from myself, and we're going to have two sets of panels. These panels will have really interactive dialogue talking about the importance of instilling trust in healthcare and actually how can we make healthcare better to improve racial outcome disparity, mortality difference in the United States and in other countries. So I'd like to start by having our first presentation or introducing my co-moderator, Maima Carmo. And Maima, I believe, has a presentation here. Thank you.
Hi everyone, I'm Maima Carmo. I'm the president and founder of the Tiger Lily Foundation. I am a 15-year breast cancer survivor, Thriver Warrior Unicorn, and I'm proud to be here today as one of your moderators for this special and important and transformational session. I want to thank San Antonio Breast Cancer Symposium and AACR for this historic session and this collaboration and commitment to ending racism and barriers to care. Our talk today marks our second annual activation, bringing together patient experts, researchers, providers, in conversations led by leaders at SABCS. Our session last year was frankly historical. It was the first time that we'd had a female-led, immigrant-led, patient-led conversation on health equity with patients at the table discussing ways to collaborate and achieve means to end barriers to healthcare disparities in our lifetime. We discussed innovative posters focusing on solutions to barriers that negatively impact healthcare for Black and Brown patients and ways to end those barriers. This year, our session is going to be epic. It's a bit different from last year's session. We're focusing this year on the social contract that binds us all. That social contract is all about trust. Over the past year and a half, the entire world stopped, stunned by seeing how racism permeated our worlds and our healthcare systems. And whether enraged or embarrassed, the entire world for once focused on one thing. People think this problem is too big to solve, but it's not too big to solve. The call for equity continues to echo within our healthcare system. It echoes in policy halls, it echoes in insurance companies, it echoes in geographical barriers, financial barriers, it echoes in biases in our healthcare systems that impact patients disproportionately. And it also echoes in the bodies of our patients. We find that patients are still having to advocate for themselves and come to tables, frankly, that may not see eye to eye with them because of trust in science and healthcare, or because they don't understand where we come from or where we live, work, play, and pray. And so for us to see real change in our lifetimes, science cannot exist without connecting with the souls of people that it was meant to serve. Science must marry with soul. This very conversation we're having today, putting patient experts together with science and research and providers, is the kind we have to have. We build trust by listening to people, listening to hear and not to combat. We build trust by learning what patients have to say and learning what their lived experiences are. We build trust by leaning in and asking, what can I do? How do I use my privilege for power to make a change for you as a patient and foremost as a person living with cancer? We build trust by then leveraging what they've told us to transform our healthcare and clinical trial systems. So if you had one superpower you could use, one gift that you could use to work to end barriers in healthcare, what would that gift be? What would it look like? What is your one gift that you and you alone have to offer the world to achieve this nirvana in our lifetime? So a quote I love by the poet Rumi says, "The universe is not outside of you. Look inside yourself. Everything you want, you already are." And so all that we seek to achieve today is already inside of each and every one of us. And what that means for me and for you is that what you think is too big to solve, these problems are not too big to solve. The solution lies in each of us bringing our privilege and our God-given gifts and talents and our big, audacious goals, our bold goals to the table, and making specific, measurable, tangible, time-bound commitments to achieving these commitments. Transformation starts when we really think out of the box and we dream big to create the solutions that we seek to see manifested in our lifetime. But that starts with me and starts with you making investments beyond the dreams, investments of individual change, looking at our innate biases that we all have, taking our money, investing our money and our time, in our sweat, and dismantling barriers and systems that don't work, that are in a sense contributing to loss of life for those who are Black and brown. I always say that we can do anything and everything is possible if we commit to making these changes. I always also say that these things are possible because I am possible. And if I am possible, so are you. Thank you.
Thank you, Mema, for those inspiring words. And so now, allow me to introduce our first keynote speaker, Dr. Lori Wilson, who's been at Howard University since 2011. She's the first and only female African-American general surgical oncologist in Washington, D.C. She also joins the staff of the University College of Medicine, Department of Surgery, Division of Surgical Oncology, and serves as the program director for the General Surgery Residency Program. Dr. Wilson is a graduate of Georgetown University School of Medicine and is currently a member of many surgical oncological organizations. She works closely with the multidisciplinary team to provide treatment, individualized treatment for each patient, and our expertise includes the treatment of endocrine tumors, soft tissue, gastrointestinal, and of course, breast cancer. And she has a long-standing interest in solid tumor translational cancer research and health disparities. So join me in thanking Dr. Wilson for coming today.
Thank you very much. Thank you, Dr. Pearl. I have to actually take a look around and take this moment all in. I really appreciate the opportunity to come and share on such an exceptional platform. It's a privilege to speak with you today, of course. I'm truly honored, and though I've spoken in many places, I doubt that I've addressed any audience that's quite like you. You must understand that this actually is a full circle moment for me. 19 years ago, I actually was doing and preparing for a plenary presentation at San Antonio. I gave my first oral plenary presentation at San Antonio, and it was titled "A Blood Test for Breast Cancer Detection." And it focused on a novel approach toward the development of a rapid blood test for breast cancer using the Cyphergen, now kind of defunct proteomics platform. It offered an adjunct to mammography for the earliest detection of breast cancer. And in that moment, it was exceptional for me. A young woman who never thought that she would have that particular moment to share with over 5,000 people the work that had come out of the opportunities that I had in my fellowship to work with one of the most dynamic researchers at the time, Dr. Donald Morton. Since then, science has advanced and so has my journey with breast cancer. Today I stand here bringing greetings from Howard University Hospital and Cancer Center, where I'm blessed with my dream job. As you heard, I'm a cancer surgeon and I'm Division Chief of Surgical Oncology. In this role, my work has evolved to answer the questions that have become even more relevant to me and my patients, and that is, how do we tackle trust in science and healthcare? So often our personal narratives give context to who we are. And some of you may know my story, but some of you may not. And so I stand here not only as a cancer surgeon, a researcher, an educator, and the first tenured female professor of surgery in my department, but also I stand here as a breast cancer survivor, especially a metastatic breast cancer survivor. It's been 8 years since I was diagnosed with breast cancer on June 28th, 2013. I was diagnosed at 2:20 in the afternoon. And I remember that moment because moments like that you never forget. My cancer journey began with 230,000 other women diagnosed with invasive breast cancer, 27,000 who were African American women like me. And as a patient, and as many do after hearing the words, "You have cancer," my family and I looked to give the journey purpose. So we shared our lives during treatment in the Ken Burns documentary. If you remember back, that documentary was called Cancer, the Emperor of All Maladies. I was actually the breast cancer patient that they followed in that documentary. It was our goal to share the moments of our family's experience outside of the hospital, outside of the doctor's office, outside of the infusion center. And moments like that fill the gaps between the office visits. It gives us insights about the realities of our journey. And it gives us the understanding of the patient barriers and the societal social determinants of health. Honestly, I have no regrets because out of all of this, not only have I become a better clinician, a better educator, a better advocate, I have found not only that I could be effective providing patient-centered care, I also can give a voice to many women who may never have the opportunity or the platform to critically understand their journey. And though treatment has not been easy, the most challenging part of my cancer journey was in 2019, only months after celebrating my 5-year remission milestone. I was diagnosed and hospitalized with hip pain and learned that my breast cancer had not only returned, but it had metastasized. And in these times, you realize as a surgeon, as a patient advocate, that there's still so much that we don't know about cancer. For me, it was a call to arms. And as a believer in evidence-based medicine, I looked for clinical trials to join. And though I am disproportionately overrepresented in the breast cancer diagnosis, I am underrepresented in clinical trials. And I think about the moment that I was diagnosed as being metastatic, thinking about what do I do next? And for me, it was to know that there were options out there for me. I found myself with limited options on the other side of the conversation, realizing that we had hit a wall. And so what was I going to do next? In my search to find another trial, my clinical care team listened to my concerns, my goals. Over time, we built trust. While identifying a new trial and treatment plan, today I stand here with no evidence of disease as a true devotee of clinical trials and value-based care. and what have there's so much, and what have they have honestly to offer, and improved quality of life, and the ability to live my life and to continue to do what I love to do as a surgeon. Being a surgical oncologist, I spend a tremendous amount of my time in search of answers, many times leading to an operation or a treatment or a cure. As attending, I had a team of residents, of interns, of medical students, and we all team with the patient to provide care. And as a doctor and as a patient, I have come to realize we also have to believe and trust in something that is greater than ourselves. It is about that connectedness and to one another, and that is what the session embodies today. Together, advancing health equity built on trust. And I hope it's okay for me to take off my mask. I think we are far enough away. And so to elevate the conversation of trust in science and healthcare, we must include health equity in the discussion. Every one of the 281,000 women who will be diagnosed this year with breast cancer is unique, and they deserve equitable care. My goal has always been focused on making sure that everyone has a fair and just opportunity to be their healthiest, removing all the barriers on equities that make outcomes different, whether those disadvantaged are social, they're economic, or environmental. It has shaped my perspective, it has shaped my voice, it has shaped my advocacy. It also has given me the opportunity to learn more, to do more, and to realize that we have to do more together. Our work at Howard University in the assessment of behavioral beliefs exhibited by African American practicing physicians began as a work that I was interested in, that I mentored. We looked toward clinical trial research and the translational leadership, which helped us design an empirically grounded form of a leadership model. And this model, with a commitment to higher order values and goals in a manner that motivates our faculty to achieve mutually recognized objectives they may not have wanted to achieve on their own. But together, we were able to come up with some amazing opportunities. Whether it was defining those programs for making sure that African American practicing physicians were involved in attracting clinical trials research to their organization, or whether as a program director of surgery, I was involved in our PACS trial, a PACS trial that was focused on providers' awareness and cultural dexterity toolkits for surgeons. It was essential for us, and it's essential for us to know that we must teach our leaders of tomorrow with our current studies of today, how to build trust with our cross-cultural care of curiosity, of respect, and of empathy. There's so much work to be done in our understanding of metastatic breast cancer, and that's why this conference and conferences like these are vital. As clinicians, policymakers, industry leaders, and patients, we must continue to come together to make trust in healthcare our priority. In my work at Howard, I have the distinct opportunity to serve at the only HBCU, historically Black college or university, on a campus that's an HBCU campus in the United States, or as a matter of fact, in the world. I'm able to serve the diaspora of the patients with the greatest diversity in the country. I spend my days partnering with women to help them understand the world cancer that has now become their diagnosis, what that diagnosis really means, what the treatment will do, and how they come toward their future. in a more real and relevant way. It's about developing trust in science and healthcare, and that's why we're here today. As we partner with our patients, we must meet them where they are, take every opportunity to ground them in the shared diagnosis of breast cancer. We're able to affect change in the lives of patients that are often under-resourced and marginalized. At Howard, we're able to make a difference through grant funding, of course, directed to reduce barriers, to discover new ways to treat and manage cancer, and to shine the light on the causes for health disparities. But what statistics tell us is that we must do more. I know that I do not work in isolation, that many of you also are on the front lines making strides about what statistics tell us, and that what we know is that it is not enough. The incidence of breast cancer in Black women has shown us that it has converged with white women. And as Black women, we are disproportionately affected by breast cancer, and our mortality rates are worse. What we're doing is not quite enough. We must do more. And in the trust element, trust is perhaps the foundational element for developing and maintaining a relationship with our patients. I have found this to be true whether it's in the confines of my safety net hospital, the ivory towers of my fellowship with the $35 million program project grant, or in the exam rooms where I have diligently worked to provide an open line of communication by changing the way we gather information for our patients. At Howard, we began by developing an assessment of behavioral beliefs exhibited by African American practicing physicians toward clinical trial research. It was a project that I thought would be interesting, but what I didn't know, it would change the way that we saw our patients and the ways that we treated our patients. What grew out of that research was that our patients actually communicated differently and more comfortably when we let our H&P gathering efforts with a simple life check. And before we even began to discuss the medical information gathering, we asked them, how are you doing? What's new? Have you seen your primary care doctor? What does your primary care doctor say about what you need to do next? We were able to establish this new way of gathering information that was really rooting our visits in a conversational sharing. We expanded this work by looking at the elements that could make us clinicians that were more connected to our patients. So each time our team was blessed to connect with patients, as the clinicians, I did what was called an internal check-in. In essence, our clinicians were given the opportunity to say, am I capable of hearing what my patient has to share? We noticed that an improvement in our patient satisfaction surveys were through the roof, that our student evaluation surveys of our clinicians went through the roof. The existing empirical studies in the literature on trust are far from robust, but there is data that says greater trust is established when the patient-clinician relationship demonstrates a pro-relational behavior rather than practices that show self-interest by the clinician. We delved into that, and what we were able to do was we began to study this at Howard. How to improve the clinical trial enrollment. We observed that the attitudes and the relationships in our studies at Howard there were some secondary points that came out of this, that we saw between our clinicians and our patients, that when we use this style of data collection, that our patients felt more linked to us. Without this linear sort of collection of data, sort of, what are you here for? Tell me what your recent medications are. Tell me what the standards are for our usual H&P. We stepped away from that and stepped towards a conversational look at how our patients that we found liked to communicate with us. And what we noted was that we were able to establish stronger trust in relationships between these patients, and that we were allowed to when they were allowed to tell their own stories, they were able to build these teams, and they benefited from the therapeutic alliance between the patients and the clinicians. We began to see more adherence to our ask. We began to see more compliance with what we asked our patients to follow through on. It turned out to be a success. We next utilized this trustworthiness scale, and what this did was really demonstrated that our patients' respect was one of the best predictors that we had in our studies of the patient's overall assessment of their doctor-patient relationship. What we found was that the greater the respect, the greater the trustworthiness. The disrespectful behavior, when that was noted, remained to be one of the most important barriers for building trust with our patients. So this study was designed to improve enrollment. It wasn't really built to assess the trustworthiness of relationships. But like many studies, you get there, and you get there with a whole different sense of what you were looking for. But in the greater good, we were able to establish a new style for our patients that allowed them to understand how we wanted to communicate with them and how we wanted to listen to what they had to say. And so it has demonstrated a good internal consistency and reliability when we've used this in our studies. It's a small study, so we're looking to expand it. We designed this out of population knowledge. I always say you have to know who you're serving. We know who we're serving. I've spent 10 years every day trying to figure out how do we do that best and how do we do that better. And with that serving and designing our study using an atypical style of information gathering, we have found that this preliminarily has been successful. It has identified a number of questions that can be investigated empirically. We must think outside the current paradigms to provide innovative ways to look at the challenges of breast cancer. And we must give breast cancer patients ways to enhance the understanding of their journey and the quality of their experience during treatment and recovery. We must support the front lines. We must infuse the fight against breast cancer with a focus on educating, advocating, and supporting individuals in a culturally relevant way. It is through our focused actions and work that we can bring our unique voices to the solution to influence public policy and resource allocation that benefits the closing of gaps in cancer care. We must feel empowered to walk away from today and to work together to affect change that will enhance the benefit of scientific advancement, to improve health literacy, clinical research participant rates, and survival rates. And more importantly, every one of the nearly 282,000 women who will be diagnosed this year deserves equitable care. That's the guideline and the evidence-based care that is designed out of best practices that are extrapolated from the knowledge of the patients that we serve. Each diagnosis is a story that adds to the tapestry of our knowledge of breast cancer. We together can impact health equity through a collective approach that is rooted in innovation, that promotes prevention, access to quality care, and new relevant treatments which are not new to you. But it's important for us to put them together differently and to make sure that we're listening for every opportunity to make change. So what is trust in a surgeon-patient relationship? How can we benefit and do no harm? We'll spend today exploring these concepts: trust in science and healthcare, equity in research and patient care, as well as diversity in clinical trials. Trust is fragile and hard fought to establish through knowledge and consistency. I am thankful for the opportunity to be here 19 years later, to have a life that is well lived with a diagnosis of metastatic breast cancer, to be able to look back and know that I've been able to make impactful change in the lives of my patients. That's my goal. I thank you for the opportunity to be here, and I'm sorry that I used notes. Many of you all who are breast cancer survivors have your idiosyncrasies. Mine is forgetting something that I may have to tell you. And so even though chemo brain is not something that I have had to really struggle with, it's something that I struggle with. And realizing that each and every one of those things that we keep inside are things that our patients really want to share with us. So in closing today, as you listen, identify the opportunities for you to empirically develop next steps for your own program, for your own patients, for your own communities, to build trust in science and healthcare by engaging patient advocates, policymakers, researchers, and industry leaders. And together, we will advance health equity. Thank you so much.